Hi there, welcome to this 1.5 hour long webinar, good for 1.5 hours of CEU on pulmonology and lung surgery. So in this webinar, I'd like to explore with you the anatomy and physiology of the lungs and the pleura, namely. We'll review some of the intrathoracic structures otherwise for context, but mostly looking at the lungs. Also some common and some interesting diagnoses and conditions that occur, and kind of some rough pointers on how to code those. And as far as procedure coding, we'll delve pretty heavily into CPT coding challenges. No PCS, so this is for prophy and outpatient coders. Hopefully you find something of interest within. So I'd like to have ready at hand these references you see on your screen here, particularly CPT Assistant and the CPT Manual. I'll also be doing some reference to diagnosis coding, so having your I-10 CM manual handy is good. I tend to like not to cram a bunch of codes onto the slide, but rather reference a range of codes, both in CPT and ICD-10 CM. So having your book open and ready, and pause the presentation if you need to find that, and as we poke around. Now the CEU credit is 1.5 hours. The presentation will be about that length as well. And you earn your CEU credit by taking the post-test. After viewing the CEU here, you'll find a link to that test, along with the link to this presentation. And with a passing score, you will receive your certificate for AAPC or Empyema immediately. And the course is good for CEU until April 30th of 2019. So my name is Ed O'Byrne. That's me over there. Before I was a coder, consultant, and educator, I was a physician assistant. I worked in emergency medicine for 11 years and had a good time at that, but it turns out I much prefer to read about and critically think about medical records than patient care. Although it was good for a time, it was not going to last me forever, but I like to bring with that my clinical experience and feel that coders can always benefit from having a deeper insight into anatomy and physiology and pathophysiology. So when reading the medical record, they're just that much more fluent in what they're reading, and we can do our jobs as coders in translating that information into the codes. Currently, I work for Healthcare Resource Group. I'm the Director of Revenue Integrity and oversee the consulting, education, auditing of our clients' coding departments and any related processes too, and it's a ton of fun. So the lungs themselves involve many different specialties. So you, depending on what practice or area that you code for, lungs are likely to come up. Pulmonology, of course, is the medical aspects of the lungs and can be purely medical treatment, but pulmonologists also perform bronchoscopies, and we will delve into some of those procedures, as well as, of course, many of the conditions that occur that pulmonologists treat. Pulmonary arteries can be involved in pulmonary embolism, pulmonary hypertension, a few other associated conditions. So vascular surgery will play a part in treating those conditions as well. Thoracic surgery, you think about a CT surgeon, cardiothoracic surgeons, it's just doing heart surgeries, but these are the physicians who work on any of the intrathoracic organs, and that includes the lungs too. So cardiothoracic surgeons commonly will perform lung surgeries. We'll look into some of those. Lung transplants involve usually a transplant surgeon and or team, and a medical doctor who treats the anti-rejection component of the transplant itself. So you might run across either or both of those. And then finally, allergy and immunology would seem to be involved in more like the skin and upper respiratory tract, but don't forget, asthma is an inflammatory condition of the airways, the mucosal membrane, so immunology and allergy play a strong component. And believe it or not, there are some procedures nowadays for asthma beyond just medicine too. So we're looking at the pulmonologist often performing those, but you might have a kind of an advanced allergist or immunologist who will perform the kind of procedures they'll look into. The learning objectives, which are required by the governing bodies for the CEU, you'll see here, I won't read them to you, but we'll look into the diseases, anatomy and physiology, and look into some of the common and or challenging procedures that are done for those conditions. So first we'll review the anatomy for familiarity. Forgive me if I belabor this a bit, but I think one, it's very interesting, and two, it's important as you read about and then code these conditions to have in your mind's eye the relevant anatomy too, and always having a good book handy is good. So we'll look into the anatomy and physiology, then a sample of the diseases, and then finally into the procedures. A good half of the presentation is about the procedures. So we'll look in the anatomy, pathophysiology, and those are only some of the procedures that we'll look into right there, as you see. Let's take the entire thoracic anatomy to start with, and we're mostly focusing on the lungs, trachea, bronchi, the great vessels, pulmonary arteries, and pulmonary veins don't see a lot of action, and the lymphatics. The heart, of course, is also in there. The thymus is a sort of effectively a lymph type tissue that sits right above and in front of the heart, is large in infants and is small in adults, and is not depicted at all in this diagram here. The diaphragm is the lower border of the thoracic cavity, and that is commonly referenced in operative reports and conditions, so forth, as that demarcates the thoracic cavity from the abdominal cavity. First, let's look at the lung lobes and the surface landmarks, the fissures. Now, the lobes, that concept is critical for CPT coding, and the right lung has 3 lobes, superior, middle, and inferior, and they're not cleanly sliced laterally, top, middle, and lower. They're each kind of wedge-shaped, so you'll see that the middle lobe is very prominent anteriorly, as we're seeing this here, but posteriorly it comes to a point. So listening to a patient, for example, auscultating their lung sounds, the middle lobe has to be auscultated on their patient's side or anteriorly. You can't really hear it in the back. I digress. The left lung has 2 lobes, a superior and an inferior. Now, functionally, the lingula acts like a middle lobe of the left lung, but technically it derives its bronchus from the superior lobe bronchus, so it doesn't count as a middle lobe per se. So the left lung has 2 lobes here. The fissures that separate the lobes are common landmarks for like VATS procedures, thoracoscopy procedures, and are occasionally seen on radiology reports as being, for example, if there's a pleural effusion that sort of insinuates itself into the fissures, they will then show up more prominently on x-ray and guide the radiologist to making a diagnosis. Then on to the segments of the lobe. So these are the subsections of the lobes. Don't worry about memorizing any of these. Just know that you will see these commonly in bronchoscopies. And there's also a not super common CPT procedure, a segmentectomy, for example, a cancer that occurs in the apical segment, let's say, of the left lung. That may in fact be amenable to resection, just taking that one segment off and not the whole lobe. Now, lobectomy is frankly much more common. And you can imagine a lot of these segments are somewhat harder to get to for a resection. Like the apicals are pretty easy because they lie on a sort of a peninsula, easily sectioned off, whereas some of the like the lingula, lateral basal, these are sort of buried up inside the lobe, so more common to see that whole lobe taken out too. And the names of these segments are very intuitive as far as the anatomical location: anterior, posterior, superior, inferior, and so forth. So just make a note of that. And there are codes, again, for a segmentectomy separate from a lobectomy in CPT, so important to take note. And then finally down to the next finest division of the lung structure, the airways themselves. So this is where the action happens. So the trachea is the windpipe, of course, splits into the main stem bronchi, right and left. And then furthermore into the lobar bronchi, you see here in colored for the superior in red, inferior lobes in blue on the left, and then of course there's a middle lobe on the right here, you see it in yellow. And then these further demarcate into the segmental and then subsegmental, or any airways past that 4th turn between the main stem, the lobar, the segmental, and anything past that. So in a bronchoscopy, the pulmonologist usually will just sort of steer their way, and just like following a roadmap, down into the subsegmental level. And that's when the airways get just a little too small often to pass a bronchoscope. And that's when you see the likes of a bronchioalveolar lavage, in which the fluid injected sort of acts like an instrument to go further in than the bronchoscope itself can go to get cells out for evaluation for infection, malignancies, and that kind of thing. And then on the microscopic level, the parenchyma, that's the stuff of the lungs. Parenchyma refers to, in any organ, the sort of the functional unit on a microscopic level, the matter that forms it, are mainly alveoli, and those alveoli are full of air. So really, I mean, our lungs are 95% air when fully inflated, you might say. And bronchioles are the final little, last little bit the airway that ends in the alveoli. And the alveoli are surrounded by capillaries, first arterioles, which anastomose into venules, which in the lungs often refer to the blue as being the arterioles because it's deoxygenated, even though that sort of contravenes the usual red-blue in the rest of the systemic circulation. But anyway, once it's oxygenated, it becomes red in the venules on its way back to the heart to be pumped out into the systemic circulation, now oxygenated. Now, there is a space between the alveoli and bronchioles called the interstitial space. So it's neither in the blood vessels nor in the lumen. It's interstitial space, the so-called third space. And there's interstitial space throughout our entire bodies. It's just a place that fluid can collect when there's local inflammation or congestion of some sort. So you'll see referenced in radiology reports commonly interstitial markings are increased. That's where that fluid is showing up on the x-rays, is all sort of in the sponge of the, in between the alveoli, sometimes with, sometimes without fluid in the alveoli themselves. Now the Bronchioalveolar Unit is that terminus. The alveolus means in Greek, in some derivation, a bunch of grapes. So you can see why that is here. This sort of taken apart view better illustrates the bronchial smooth muscles. You see right here, encircling the terminal bronchiole there, and they are in fact innervated. You see these yellow nerves that go to those muscles and can cause them to constrict and therefore restrict the airflow through the airway. Now the protective mechanism is to avoid aspiration of solids and liquids into the alveoli. That this acts as a check valve to prevent it from going any further. But the flip side to that normal adaptive process is the pathophysiology, which is asthma. That affects those smooth muscles, something which we'll touch on a little bit later, and that many of the treatments are involve affecting neurotransmitters in these nerves that innervate those smooth muscles too. The vascular supply to the lung is, of course, twofold. The main function of the lungs is to oxygenate the blood and decarboxylate, that is to release carbon dioxide generated through metabolism in the body out into the atmosphere. But the lungs are living tissue as well, so then naturally they need to derive some nutrition through that same blood. The vascular supply to the lungs is derived from the pulmonary arteries, which you'll usually see depicted as blue, like here, through the pulmonary trunk that comes out of the sort of the top back of the heart, leads into the pulmonary arteries, and then back through the pulmonary veins with oxygenated red blood. No blood is really blue, but it's darker, so let's just think of it as deoxygenated blood as being the blue. The hilum describes the place where the vessels and the airways all kind of come together in this sort of pinched area at the center of the lungs, where it enters the mediastinum, going to and from the heart and so far as the vessels, and to and from the trachea as far as the main stem bronchi. So the hilum is right here and right here. It's an anatomical site where a pneumonectomy is performed. When the entire lung is taken out, that's where it's taken. And the hilum is a very common area you'll see referenced on radiographic readings or surgical procedures as kind of the landmark to help orient you in your mind's eye what's going on with the procedure, for example. Chest x-rays will commonly remark on congestion around the hilum or lymph prominence around the hilum, because that's where most of the lymph vessels are. So speaking of the lymphatics, also found throughout our body, and commonly at areas where there's a junction between a limb and the body or an organ and its outgoing circulation. For example, in this case, right around the hilum, you'll see a concentration of lymph nodes too. And there are lymphatic vessels which extend down into the parenchyma of the lungs as well, are there to act as sentinels for infection and malignancy. So the next stop for any malignant cells exiting the lungs is often through those lymphatic vessels and into a lymph node. So they're affected by metastatic cancer of the lung. These are the lymph nodes affected first, will often show up on x-ray first, and are the target for biopsies done by bronchoscopies to evaluate for cancer in the lymph nodes and or in the lung parenchyma itself. The lymph nodes can also enlarge in response to infection in the lungs or around the lungs and can show up on x-rays. And then they can also form cancer themselves. Lymphoma is the main cancer that affects the lymph cells. And the lymphoma is simply a swelling of the lymph cancer somewhere in the body. Lymphoma doesn't per se metastasize, but it can pop up in several different areas, and the chest is actually one of the more common ones to show up. Now the chest wall, we'll go into a little bit just to understand the outer demarcation of the lungs, not to focus too much on the procedures there, except the pleura itself. But it's important to note for the anatomy too. So from the outside in of the skin, the chest soft tissue, the subcutaneous tissue, a little bit of fat, then the ribs and intercostal muscles. The parietal pleura is the first layer that you come to from the outside in. So a pleurodesis punctures through the parietal pleura here, but not through the visceral pleura. The visceral pleura surrounds the lungs themselves. Viscera means, in effect, just organ. So anything referring to visceral, you think about, in your gut, it's a visceral thing. It's the layer that's on the gut or on the organ. So the visceral pleura is here on the lung. So thoracentesis, the needle enters the pleural space between the parietal and the visceral pleura here. So that's the pleural space, and it's really more of what we call a potential space. It has a tiny little bit of lubricating fluid under normal states, but it can open up between these two layers and hold many liters of fluid in the pleural space. So then, of course, we got to the visceral pleura and the lung parenchyma itself. So to drill down that a little bit, so the visceral pleura, to dive in a little deeper, is where Lobes and bullae form. That is on the lung, not in the lining of the chest wall. Decortication, which we'll review in the CPT coding, is of the visceral pleura, not of the parietal pleura, typically. So this stuff in an empyema that sticks to the lung sticks to the visceral pleura, not as much to the parietal pleura. So you'll see a peeling or decortication is of the the visceral pleura. Spontaneous pneumothorax. Now you have a couple different kinds of pneumothorax. Pneumothorax just means air in the thorax, in the chest. The spontaneous pneumothorax from a puncture or rupture of a bulla or just a weak spot due to malignancy, congenital condition, or anything is through the visceral pleura. So that is air that's gone into the lungs through the airways and then out through the visceral pleura. Now the parietal pleura is if there's a traumatic pneumothorax from a penetrating injury outside the body through the parietal pleura, and that lets air in, that's a different type of pneumothorax. They're actually treated the same way by inserting a chest tube and sucking that air out, and then addressing the cause of the leak, whether it's external or through the lung. Pleurectomy is done of the parietal pleura. So you'll occasionally see this for a variety of conditions, but when the parietal pleura, for example, is involved with cancer, it'll be stripped away, whereas the visceral pleura is kind of what contains the lung. So it's small areas can be taken off, but you can't peel off a big piece of visceral pleura and just expose all the alveoli and parenchyma beneath. It's just not really done. So speaking of a parietal pleura, a little fun with cuisine here, and here's your first CPT code 32310, parietal pleurectomy. So here are some spare ribs. You'll see the lining there is the parietal pleura. It's very thin, it's very slick, pretty strong too. I think you're supposed to remove that before you cook ribs, but there's a good illustration of it. And I couldn't stop there. It was fun enough. I had to throw in one more CPT code 19260. It's chest wall resection. These were some delicious ribs I had in San Diego once, and there were a lot. So it was an unusually difficult procedure to get those down, hence the 22 modifier. So promise that's the last food I'll have in the presentation. But I have to insert this gratuitous picture of my kids who were along with me for that trip to San Diego, in which I tried to do at that same restaurant, same chest wall resection, only the line was around the corner. So we had to discontinue that procedure before I got into have a cold one, but I was able to go back later and get it. Okay, back to business. So now pathophysiology. So that's enough anatomy. These are some of the conditions which we'll look into. Some of these are probably common to all of our coding practices. Some of them are a little bit more specific, but chances are you're going to run across all of these at some point in your coding career, inpatient or out. Empyema, It's probably one of the lesser frequent ones. These usually end up in kind of referral hospitals, but the diagnosis of these is ultimately usually made in an outpatient setting to begin with. So starting with pneumonia, we will all have coded pneumonia. Many of us will have had pneumonia at some point in their life. And it's got several different related processes going on. It's not just usually not just a straight infection that causes the problem. It's the inflammation that the body mounts against that infection is just as bad as the infection itself. The fluid that results from that inflammation fills airways and interstitial spaces and impairs function of the lungs. This can cause fluid and inflammation in the bronchioles and the alveoli, or both, and as I said, the interstitial spaces as well. So you'll see a typical chest x-ray here of a patient with pneumonia, and in the right middle lobe here. So unless mentioned otherwise, all of these chest x-rays will be patient facing back at you. So our left is patient's right, and our right is the patient's left. So you'll see in healthy lung on the left here, it's very radiolucent. So that is, the x-rays pass right through the lungs that are otherwise full of air with just a tiny little wisp of vessels and interstitial fluid here, whereas bone is very white, doesn't permit x-rays to go through much at all, and the heart is full of blood and it's muscle, hence minerals, doesn't admit a lot of x-rays through to the film. But this right middle lobe has an increased concentration or ratio of fluid and minerals to air, which is why it impedes the passage of chest x-rays and therefore shows up white too. So interstitial markings are increased, and this goes right out to the periphery of the right middle lobe. So this is a pretty socked in pneumonia. Now pneumonia is, we typically think of as infectious, but it's not, it's mostly not in chapter A and B of infectious diseases in ICD-10-CM. There are a few systemic diseases with pulmonary and systemic infectious diseases with a strong pulmonary involvement, like chlamydial pneumonia or Legionnaires disease, as you'll find in chapter A. But by and large, you'll find them in the pulmonary section J of ICD-10. And I have to theorize it's largely because, like I said, it's not just a straight up inflammatory, a straight up infectious condition, but there's inflammation and all sorts of other manifestations, which are more sort of pulmonary in the way that they affect the body and less infectious. But I digress. So the infectious pneumonias you'll find in this range of codes, J12 through J18, by the organism if known. And there's not all the potential bacterial pneumonias have a code for them, but there are others. And then by illustration of the distinction between aspiration pneumonia and infectious pneumonia, I've put in inflammatory J68, which comes before J69, which leads me to believe that in the nosology of ICD-10, they're truly treating aspiration pneumonia as an inflammatory condition of the lungs more so than an infectious. Now, as a clinician, I will tell you that aspiration pneumonia is virtually always infectious as well. The patient is going to inhale vomit. It's got bacteria in it, and it causes a tremendous amount of local inflammation, which makes it much more susceptible to infection. So it's always treated with antibiotics. Now, of course, vomit is hydrochloric acid too, so there's an inflammatory component to it as well. But this can cause some kind of interesting perspectives on the coding, which we'll look into here. Also, these J68 inflammatory pneumonias, if by external agent, some sort of toxin, oil, etc., we'll need a T code to go along with that to describe the offending substance. So let's check into the pneumonia and aspiration pneumonia. Okay. Pneumonia not otherwise specified, J18.9, is the one we use all day long. And let me digress quickly to say that in a lot of clinical settings, it's not possible to know that if the organism causing the pneumonia, even if you've got a sputum culture, those are so commonly contaminated with a bunch of different bacteria, it's just really hard to know. So go easy on your providers if they don't specify the organism. However, there's a little bit of a workaround, a little bit lower in this slide too. Nonetheless, pneumonia not otherwise specified and aspiration pneumonia have an excludes one note, so you can only use the one, okay, one or the other. Aspiration pneumonia chiefly, if that's what's stated. You throw away the pneumonia not otherwise specified. However, bacterial pneumonia, there is no such excludes note too. So what and I digress again in a sort of a CDI direction too, is if you have any influence over your provider's documentation, is if, gosh, if they're treating this pneumonia, aspiration or otherwise, with antibiotics, have them document bacterial, and if it's inpatient, possible or likely bacterial pneumonia will give the coder, me and you, more to work with at least. I wouldn't be surprised if their excludes note gets added at some point. Just kind of keep an eye on that. Now, if we're lucky enough to know the actual organism itself, like Klebsiella, commonly a hospital-acquired, or E. coli, similarly, there are specific codes for those too. But the take-home message there is that bacterial pneumonia and aspiration pneumonia can co-occur, if documented correctly, can be coded together, at least as of the time of this recording. Alrighty, COPD is a super common condition as well. There's a small section that pertains to COPD, and there's some interesting coding rules that pertain to COPD. So we have the usual sort of outpatient comorbidity, the COPD not otherwise specified, not an exacerbation, not infected, as a patient is getting their MDIs refilled and so forth. Then we've got the patient in the ED or admitted patient with an exacerbation of COPD. Now, if that is exacerbated with a lower respiratory infection, which is commonly the case, we've got this sort of add-on code, J44.0, and we want to note what that infection is. So you need to also code what the infection is, pneumonia, for example, and that's the main source of exacerbation or some other lower respiratory infection. So what COPD really is if you see this cross-section of one of the smaller airways, bronchioles, it's lined with a mucosal membrane, which is there as a protective mechanism, and it's also thin and moist, and at the level of the alveoli, that's the layer that allows oxygen to be absorbed, CO2 to be emitted. That mucous membrane, over years of abuse, usually from tobacco smoke, causes the mucous membrane to thicken itself in response to that irritant and increase its mucus production. So here you can see on the right, mucous membrane is hypertrophied. It's secreting a lot of mucus over this perceived, if the lung had a brain, it would perceive the smoke as an infection or irritant, and that's just how it responds. But you can see the cross-section of the airway is now much thinner and less able to allow air in and out. A closely related condition, but one which is it's still poorly understood what causes asthma, but it's an overreaction of the smooth muscles that surround the bronchioles to a real or perceived irritant, or cold air, or sometimes even emotion, or some systemically ingested chemical. It's very complex science, and there are many codes to go along with it. The main takeaways, if you want to flip to in your manual to J45, it's broken down by the severity of the asthma, so mild, moderate, or severe. And then mild is further broken down into intermittent and persistent, and then moderate and severe are just persistent. I think that the allergists, immunologists, and pulmonologists conspired with ICD-10 when they developed it into CM to get this vast variety of choices of severity of the asthma. It's rare to see a non-super specialist in asthma designate these, but nonetheless, we would love to have it as coders. Now, the state of the asthma is actually more important clinically by far, and also if we're coding inpatient, whether it's a comorbidity or complication or not. So you have this state of asthma not specified, just that's the kind of throwaway secondary diagnosis. That's not a CC. If an exacerbation or status, it is a CC to most, nearly all, I would guess, other principal diagnoses. Nonetheless, it'd be uncommon for a physician or other provider not to document exacerbation of the asthma or status. And there is, of course, other and unspecified for these as well. And you see that the anatomic result of that constriction of those smooth muscles is what looks like the very familiar from the COPD slide, constriction of the airway. And the treatment is, again, directed at effectively chemically denervating this parasympathetic nerve fibers that go to those smooth muscles, too, with the likes of albuterol. On to pleural effusion and hemothorax. So this is when I made the emphasis of the pleural space between the visceral and parietal pleura. This is where the action happens for effusions and hemothorax among the J90 through J94 codes. and it can be fluid in effusion or blood in the hemothorax. So further to break that down, the pleural effusion can be transudative or exudative. This can only be determined from a thoracentesis or other acquired pleural fluid. That's the common diagnostic procedure that's the least invasive and just to establish a diagnosis. A transudative occurs when the fluid inside the circulation around the lungs and inside the pleura sort of leaks through the pleura itself. So it's low in protein, it's got a moderate amount of electrolytes, and if you find this in congestive heart failure, kidney disease, pleuritis, where the pleura itself is inflamed and it just becomes leaky. So the proteins stay in the circulation, the fluid leaks in to the pleural space. Whereas exudative is more of an active cellular secretion of fluids into the pleural space. So there's usually a high protein, often cells themselves, and you'll see this in cancer and infections of the lung, of the chest wall, or of the pleura itself. So transudative and exudative, that's where you'll see those terms. Now, what does that mean to us as coders? Well, if it's exudative, you think cancer, if there's cancer cells, and there's a malignant pleural effusion code in that specific. Now, you can't obviously go to the cytology report and make that diagnosis yourself. But if you see an exudative pleural effusion, look for that malignant pleural effusion to be documented somewhere else. Now, if it's blood, hemothorax can be traumatic or spontaneous rupture of a vessel of either of the pleura, visceral or parietal, and the blood leaks into the pleural space, that potential space. So what both of those look like, pleural effusion and hemothorax, is if you look at this patient on the right, the lung goes all the way down to the costophrenic angle here. It's this nice sharp between the ribs and the diaphragm, i.e. phrenic. The lung goes right down to the tip. On the patient's left, you see that is blunted and round. And in fact, the lung is floating up on fluid there. So down here, there's blood or fluid, exudative or transudative. That would be the target for a thoracentesis, to get that fluid out and see what it is. Now, pulmonary embolus is a clot in the pulmonary arteries. Usually, this clot originates from a deep venous thrombosis somewhere else in the body, and those most commonly occur in the legs, the lower legs. But they can occur anywhere. As remember, all the blood passes back through the inferior and superior vena cava, through the right heart, and then directly out into the pulmonary arteries, at which case, so up to that point, the lumen of the veins is increased to the heart, so that a clot of any size could pass through that, and then into the pulmonary arteries is where the lumen starts to shrink back down. So that's where it lodges. So there's a couple of different views, 3 different views of this anatomically. So this is a pulmonary trunk and arteries passing to the right and left, and the clot is a little subtle, but you can see it's inside the artery itself right here. Now, that a similar kind of a clot seen on the transverse section on a CT scan, as the clot has a different sort of mineral composition than liquid blood, it shows up differently here, going into the right and left pulmonary arteries there, surrounded by fluid blood. That's the white part. This is called a saddle thrombus, PE. So it kind of rides over the right and the left. And on the right here this was a depiction of a clot coming from somewhere in the lower body, probably the leg, into the right atrium, right ventricle, out the pulmonary trunk, and then bam, depending on the size of the clot, it may stop right there, or it may go down into a lobar artery or even a segmental artery and lodge there. And guess what? That occludes the arterial supply to that lung. And if it's persistent and complete enough, it will cause necrosis of that lung, because after all, the lung is living tissue, needs blood too. It's not sufficient ability to absorb oxygen just from the air. It's got to actually have nutrition through the blood and oxygenation. So the coding implications of these are septic, saddle, or other. And honestly, the other is the one you're going to come across the most. And then with or without cor pulmonale. So the resistance of outflow of blood from the clot may cause the right heart to become enlarged and back up, and ultimately can fail completely. Just depends on the size of the clot and how persistent it is. In case you wondered about the whole clots and blood bubbles in the in the veins through the IV and that kind of stuff. Bear in mind the systemic and the pulmonary circulation completely separate from one another. So a clot that originates in the heart is the source of a CVA, a stroke, usually from the left atrium, left atrial appendage more specifically too. Whereas a clot originating from the body can't go to the brain. It's going to get filtered out by the lungs first. Same with the blood vessels in the IV. That's to a point, those are totally harmless. Okay, so there's two main ways to diagnose pulmonary emboli. There's a kind of the old school way of VQ scan, and there is the new way of pulmonary angiogram, but I'll show you in a sec. So VQ scan is V for ventilation, Q for perfusion. Not certain why it's not V over P, but in any case, this was invented by David Sabiston, as a famous surgeon who was at Duke, which is where I went to. So we learned a lot about this in the 50s, and was when it was invented. And it compares the amount of air and the amount of blood to any given section of lung. So there should be a match between the blood circulation and the oxygen, or in the air that's present there. So to assess the ventilation, the patient inhales a mildly radioactive gas, xenon-133, and they basically allow it to create an X-ray from the inside out. So by emitting the radiation from the gas out, it creates a picture as you see on the left, labeled A. And then perfusion, we use technetium-99m metastable. It's a slightly radioactive in a way. I won't bore you with the details of it, but it also creates X-rays that come out of the body and can be measured. So by comparing the amount of blood supply and the amount of air supply, let's think of it, the radiologist can determine, for example, like this area is getting plenty of air supply, but it's not getting blood right here. So this may be a left upper lobe segmental pulmonary embolus blocking the blood supply to this area. Okay, sorry to nerd out on you too much for that. Now, much more commonly, a pulmonary embolus is diagnosed on the basis of a pulmonary angiogram. There's a direct pulmonary angiogram, as you see on the slide, and there's a CT angiogram, which is much more commonly used. We'd use those in the emergency department, for example, but it's much less exciting to look at. So let's look at the direct pulmonary angiogram. So a CT angiogram uses just IV contrast administered in a peripheral IV, and it just sort of finds its way into the pulmonary vasculature, and this CT scan slices are taken transversely through the patient's lungs, and usually coronal and sagittal reconstructions are made so you can kind of locate where the clot is. But on this direct one, it's administered, the contrast is administered through a catheter here in the right lung and catheter here in the left lung. And this is two pictures superimposed, so this is why the anatomy looks a little bit weird. The contrast is injected, basically X-ray is taken, or fluoroscopy with a still image, and we're looking for areas where blood doesn't go, like where the contrast doesn't go. So you would see a pulmonary trunk, main artery and branch, lobar branch with no blood flow through it. That's where you know there's a clot right there. I can act accordingly on that. Now this is done in condition also affecting the pulmonary arteries, pulmonary hypertension in the I-27 family of ICD-10. And there are a few different types, and there are some new codes in 2018. There are primary pulmonary hypertension, which can be inherited or toxic, and then there is secondary due to cardiac diseases. So there's nothing really fundamentally wrong with the pulmonary arteries themselves. It's a sort of a knock-on effect of cardiac disease. That's the secondary. Now, toxic pulmonary hypertension is in effect secondary to an agent, but it's due to actual effect right in the pulmonary arteries, which is why it's classified as the primary. And then there's obstructive, where there's some stuff in the pulmonary arteries. Thromboembolic pulmonary hypertension is a kind of a tragic type that occurs where there's clot and atheroma and just garbage in the pulmonary arteries that causes the blood supply through those pulmonary arteries to be decreased. Therefore, the oxygenation is diminished, CO2 builds up, cardiac throughput, cardiac output is decreased. And so the right ventricle, you see here, can become dilated and weakened due to it. You can see the pulmonary arteries back here behind the tricuspid, but that would be the outflow tract of the pulmonary arteries. So poke around those I-27 codes and you'll see what I mean. And there's a procedure to go with the thromboembolic at the end of the webinar here. Pneumothorax, like the hemothorax and pleural effusion, is something in the pleural space that doesn't belong. Only in this case, it is air. I guess theoretically it could be any gas, but it's, as far as I've ever encountered, it's air. There are two main types, primary and secondary, and that secondary can be due to pneumonia, cancer, anything that creates a leak between either the visceral pleura here or the parietal pleura on the outside too. In either case, it admits air into that potential space you would see in this patient's right, and what's become an actual space here on the left. So the short-term treatment for these is to insert a chest tube to take that air out and allow the leak to heal on itself, which it usually does in spontaneous pneumothoraces, or until a pleurodesis or some more other definitive procedure, maybe even a lobectomy, if it's a very large leak, to cure the leak, and that will allow it to heal. If it's persistent, large, or recurrent, a pleurodesis to actually totally eliminate the pleural space is the treatment for it. So here's what this would look like on a chest x-ray. If you focus on the patient's right lung, you'll see the normal ratio of black, which is air, and pulmonary vascular markings, which is the white wispy stuff. Flip over to the patient's left lung, it's just straight black. It's almost just pure air. And if you look hard, you can see the border of the lung right here, where that lung is constricted and is compressed down by this excess air. And this patient's heart is actually shifted a little bit to the right too, if you take my word for it too. And if that's the case, what we have is a tension pneumothorax, where there's a one-way valve of the air into the pleural space and can't get out. So with each inspiration, air leaks into the pleural space, and it doesn't flow back and forth. It just continues to compress the lung, compress the lung, compress the lung, and then move the heart over, which is really a life-threatening immediate concern. Empyema, I think, is the last stuff in the pleural space diagnosis you hear is found in J86. And essentially, you have a with and a without fistula version of that in the coding. This empyema comes from the Greek for abscess. So this is a condition recognized in antiquity. I'm not sure how they diagnosed it back then. This is well before they were brave enough to actually cut into a living human. Maybe it was a cadaver that had died of this. Another term for it you'll see in the medical documentation these days is pyothorax, which just means infection in the chest, pyothorax. And it's a pus collection around in the pleural space, just like the air in the pneumothorax, just like the fluid in the pleural effusion. And the treatment for that is drainage of that stuff too. Now, unfortunately, with empyema, it's not often quite as simple as just draining out the pus like you drain out air, blood, or fluid, because infection leaves a lot of damage in its wake. So if the empyema is large, persistent, or recurrent, a pleural peel to get rid of that excess garbage that's stuck to the lung is often needed to be performed. Here's how we diagnose this of empyema. And honestly, this could be just a very large hemothorax or pleural effusion. But on the patient's transverse CT section here, you'll see they're supine, laying on their back. You have air anteriorly floating up, and then you have pus sinking down and forms a nice meniscus right across here. So the lung is just basically floating up here, and this is totally occluded. If the patient returned to an upright position, that pus would settle down to the bottom of the lung, and the lung would be up here, and then pus is down here. You can see a nice cosophrenic angle on the patient's left, nothing even close to it on the right. Lung cancer, C34. So now we've flipped out into the malignancy chapter, C as I call it. There are many, many types, and it's coded by the lobe and the laterality. And the treatment for cancer, as we're familiar with, is often chemotherapy and resection, both. Now the resections, this is a very busy area in CPT, so I'll save mention of that until we get into that section too. But it can be done through an open approach, through a scope through the chest, or bronchoscopic. That's usually the diagnostic part from a biopsy. But the lung can be gotten to in all of those different ways, hence the different specialties. Here's what the cancer would look like, or a certain type of cancer would look like in a cross-section of a lung, probably a smoker given how brown this all is. And what it would look like on an x-ray, a well-demarcated, large spherical lesion on a plain chest x-ray, which would certainly be followed up with a CT scan. Now on to the procedures. So I'll start with an easy one and really common one, bronchoscopy. If you're like me, it took a couple of months to get up to speed, and then you could mostly do these in your sleep, given good documentation to once you realize the rules and so forth. So there are many different modalities, as I like to think of them, that involve different instruments, just like colonoscopies and EGDs. The CPT is largely predicated on the instrument that is used, so pay close attention to that. Sometimes referencing the instrument forms in the nursing documentation can help solve some ambivalent documentation. There is, of course, the basic type, which is a diagnostic with or without a washing, and that's just having a peek around, squirting a little bit of fluid in there to obtain some cells. And then the more specialized types, the bronchioalveolar lavage, which is technically not just a local, like this might be in the picture, local washing of this main stem bronchus and lobar bronchus here, but rather putting fluid all the way out into the periphery of the lungs. Notice the alveolar part. That's the critical part, bronchioalveolar lavage. This is in effect using the fluid to reach all the way down into the alveolus where the instrument won't fit. There is brushing, localized brushing of the wall of the bronchus to obtain cells to look for cancer, inflammation, and so forth. An endobronchial biopsy is a sharp excision of a small amount of that same tissue. Transbronchial biopsy is through the bronchus into either some adjacent parenchyma, lung parenchyma that can't be gotten to, or of a lymph node. And it uses a very fine needle, but it's a solid tissue core. I digress into PCS coding, but nonetheless, transbronchial biopsy is a solid fluid. Now there's a needle aspiration, which is fluid, but has cells in it. That's what they're really looking for, is the cells from a lymph node or from a fluid collection or from an empyema obtained through a bronchoscopy too. Now none of these are mutually exclusive except the diagnostic. So it's not uncommon to have multiple different modalities done, like an endobronchial biopsy for solid tissue and a BAL, bronchoalveolar lavage, to get cells from further out in that lobe, for example, too. And they can both be coded. Be wary of your CPT modifiers. Always subject to change. Run your CCI edits. Don't trust what I say right now. May not apply next year or the year after that. Then there's a little bit more specialized bronchoscopies, so foreign body removal and a therapeutic aspiration. And this distinction between initial and subsequent gets a little bit of play. It's for that hospitalization. The challenges are, if you have a patient that's in the hospital for a long time and they get revisited several times, even by different pulmonologists, to perform these therapeutic aspirations to remove mucus, who's keeping track of the initial and subsequent? It often falls on us coders to help figure that out. And this is a little problematic, especially when charge sheets are used by the pulmonologists themselves, because they don't know, and they, in my experience, don't really care which one is chosen. But it should be our best effort to ensure there's only one initial code, and then each after that, during that hospitalization, is the subsequent code. Now, this should, to support the medical necessity, occur with a diagnosis of clearance of secretions, not just to aspirate some mucus fluid to see where they're going, too. Another term for this is a toilet bronch, believe it or not. Basically just sort of clearing out the pipes with a bronchoscopy. Now this is even more interesting than anything so far. Bronchial thermoplasty is, remember I remarked on a procedure for asthma. You may have seen this. If you haven't, you probably will at some point. Bronchial thermoplasty, or thermoplasty for asthma, is creating some therapeutic scar tissue that is so dense and fibrous that it cannot be constricted by those smooth muscles, as I mentioned. The CPT codes are for one lobe, 31660, or two or more lobes, 31661. It's usually not done for more than two lobes at a time. So this is a kind of a procedure that a patient needs to come back several times, because it does cause pain, scarring, and temporary decrease in pulmonary function, and the potential for complications. So they can't just scarify all the lobes at once necessary. Now, to emphasize, this is not cautery, not simple cautery destruction of a lesion. In fact, it uses a totally different energy too. Cautery destruction of a lesion uses heat. Bronchial thermoplasty actually uses microwaves, which are emitted from this special probe that you see right here, and it cooks the surrounding tissue. not just what it's touching, but anything sort of within and adjacent to these little lobes that you see here. And effectively, it scars the mucous membrane and the bronchial smooth muscles. The mucosa regenerates. The smooth muscles don't. It stays in this open, expanded state. Now, right heart cath, why I mention this, it seems like obviously a pulmonary, or obviously a cardiac procedure, but it's commonly done by pulmonologists, and it's because the right heart is the half of the heart that is responsible for pumping blood into the lungs. So right heart cath is actually often used to measure function of the pulmonary circulation, hence pulmonary arteries, hence we're into the lung. There are two main flavors that you'll find here that could be confused. 93451 right heart cath, including the measurements and cardiac output and oxygen saturation and so forth. Now this is an in and out type of procedure. So we go through whatever convenient peripheral vein, subclavian, iliac vein, and the flow naturally follows the blood back to the vena cava, into the right atrium, into the right ventricle, out into the pulmonary artery right there. So this would be something to measure what's the back pressure in the pulmonary arteries, for example, for pulmonary hypertension. And the passage through the heart is, in this context, kind of incidental. It's not as much a measure of the heart function as is the health and the flow through the pulmonary arteries. Now, they do measure the cardiac output, but that is, as it's in this context, again, governed by the occlusion or not of the pulmonary arteries. Now, when this type of procedure is done for monitoring, like in an ICU of cardiac output and oxygen saturation, we're looking at 93503. Placement of flow directed, as I mentioned, they're both flow directed for monitoring purposes right here. Now, the Swan-Ganz catheter is a special kind of catheter that is used for measuring cardiac output and oxygen saturation, and it can in fact be used for the first procedure, 93451, too. So therefore, the only reliable distinction between these is if it's an in and out study or for monitoring. Thoracentesis, to get any fluid, blood, sometimes pus, out of the thoracic cavity too. So this is being careful to distinguish. This is a pleural cavity drainage. It's not of lung tissue. And it's also not coded if it's a surgical drain. So a chest tube's put in after lung and heart surgeries all day long to remove fluid that may accumulate. Thoracentesis, this is for removing fluid or blood that is there and is causing problems or needs to be diagnosed. So air or fluid is included, doesn't matter what the indication. Coding for whether it's an in and out for diagnostic purposes, or maybe a small pneumothorax or hemothorax, an indwelling catheter, and whether it's with or without image guidance, like an ultrasound, fluoroscopy, or CT. This basically to distinguish if it's going to go through the lung or not. In a clinical setting, how we usually do this is, since the patient, when upright, the lung floats on the fluid, we just aim for the lower, like the 8th, 9th, or 10th intercostal space laterally, and just drive the first a trocar in, and then the tube around that trocar is like a nail. And this is what it may look like on an actual patient. Sometimes we actually would use a scalpel and dissect down just to the parietal pleura or thereabouts, and then shove some hemostats through the last little bit. So that, or a trocar, or a stylet, as another word for it, is like that nail that goes through the tube. Anyway, it's fun to do and causes a great deal of relief for the patient. Now, getting into the resections of lungs. Well, this is the stuff, the tissue of the lungs themselves. This is a very busy area of CPT, so you may want to whip out your CPT manual to look. The many indications for it, cancer is probably the most common one. Trauma to the lung that is irreparable or is not likely to heal on its own. It may be best just to take out part or occasionally the whole lung. Chronic infection like an empyema or tuberculosis, sometimes that's all that can be done, is just to take out the lung, the whole thing. Or if the lung itself is affected by large number or large size of blebs, bullae, that is things that can leak and cause recurrent pneumothorax, may require a lung resection, hopefully just of a segment, maybe a lobe, but occasionally the whole thing. So the coding is the same for any diagnosis as well, just like the thoracentesis before. It's the approach that matters too. So these are obviously therapeutic lung resections are never done through a bronchoscope. A diagnostic lung excision in the PCS sense can be done through a bronchoscope. But an open is, and there are some kind of hybrids of these approaches, but I think of open as hands in the chest and eyes on too. There may have been a scope previous to this to assist with it, but if the surgeon's eyes fell on lung as she was cutting it out, that is open. Videoscopic assisted thoracoscopic surgery, or VATS, that's through a thoracoscope. It's like a laparoscope, but configured a little differently and customized for working in the chest. Obviously a lot less invasive and quicker recovery, but a little harder to work with. Okay, so there are important concepts for lung resections in both open and VATS. So this you'll find in the rather small respiratory system section in CPT, starting with 32440 for the open, and then next page for the VATS. Now, each of these are available in both open and VATS. There's not a perfect overlay of these because there's certain additional procedures that can be done by VATS that you don't find in the open and vice versa, but these are the main concepts, and that's why I intentionally didn't put codes with these. So the first takeaway is the first three here you see are diagnostic, and the last six that you see are therapeutic for a known lesion of some sort or known problem. So, and it goes from, as you can imagine, least to most invasive too. So pleural biopsies, pretty obviously diagnostic. Here's where it gets a little bit weird, and this is one of those sort of cringy CPT things. I have to wonder how and why and who designed it this way, but in any case, a diagnostic wedge in parentheses, and that's usually the technique, and I'll show you a picture, it'll make more sense. Resection for infiltrate, like an infection or some sort of interstitial lung disease. Remember the third space interstitium, versus a discrete lesion. And we just pray for a good diagnostic statement to distinguish these in the procedure. And then we've got the somewhat more straightforward biopsies of something less than a segment is a therapeutic resection. Again, wedge is the usual sort of technique, but it's a non-essential modifier in the CPT descriptor. So any therapeutic resection that's not a whole segment falls into this category. And then we work our way up anatomically into larger and larger anatomical subsections of the lung, and then the whole lung itself. So a segment excision, a lobe excision, a two lobes excision, and I'll challenge you to wonder if you can do that in the left lung or not, a bilobectomy, because there's only two lobes. The answer is no. Pneumonectomy is what you'd be dealing with there. That's a removal of an entire lung. So both lobes of the left or all three lobes of the right, usually done in block, like one big piece. And then the pneumonectomy extrapleural would refer to if a patient had an invasive cancer, either of the chest wall going in or of the lung invading out across both pleura or into the at least the parietal pleura. It would be removal of the lung, the visceral pleura, which was formed the outer boundary of the lung itself, and the parietal pleura itself. So it's everything associated with that pleural space. So here's a graphic depiction of what those may look like. So we have a wedge resection. This is a little bit sort of cartoony related, but it is clearly two or more staple lines where this section is stapled across and then cut between the two rows of staples, and then one or more other rows of staples across there. That removes this section, in which is infiltrate or lesion, removal of a full segment. So right superior segment of the right upper lobe with the the popcorn in it or whatever that is. Removal of the full right upper lobe, lobectomy, and a full pneumonectomy. And whether that's done or not, if you could even imagine these popcorn lesions for cancer were the same size and same location, sometimes the type of the cancer histologically can determine whether it's likely to be localized and just a segmentectomy or lobectomy is going to work, or whether it's the kind of wicked invasive kind, and a whole pneumonectomy may be necessary due even to a small lesion. Lymphatic infiltration of certain types of cancers is more than with others and so forth, so the type of cancer can govern the type of resection that's done. So here's a picture of what it would look like in an open resection in the family of 32440, 32540. Too, remember what I said, eyes on, hands in, but at least eyes on, that tells you it's an open approach. The same would pertain to PCS, but they're two separate sections for thoracoscopic and open and CPT, which is what we're talking about. Here you can see this diseased lung right here. Here's the chest wall. There would be a rib here and a rib here. Sometimes I'll actually remove a rib just to increase access, and a special retractor put in. So this could be, a lot of the work can be done inside the chest, but just as commonly, the lung is partly removed from the body, it's stapled off, or for example, the segmental bronchus encircled, ligated off, and that segment removed. And this is what you'd see like right here. There's a chest tube going into the chest, and a clamp closing off that bronchus there. So backing up a little bit to the different flavors of types of resection. So the open wedge resection, again, for resection of infiltrate or a lesion. And then there's a code for diagnostic followed by an other resection. This would be the common case where a small wedge was excised just to enumerate the type of lesion within, sent for frozen section and pathology while the patient's in the operating room. And let's say it comes back, it's cancer, and it's either aggressive or there's not a clean margin. That is, the cancer went beyond the original resection, the diagnostic resection. Now it's turned into a therapeutic one. We have a diagnostic followed by another resection. So look out for those codes. So it's important to pay attention to the sequence of events and the intention, where it's multiple therapeutic or diagnostic and then followed by a therapeutic resection. And then we have the ordinary therapeutic wedge resection. Perhaps a patient has had a needle biopsy before, they know it's cancer or a certain type of infection, and the intention going in is a therapeutic wedge resection. So again, look in your CPT manual. For economy, I did not put the codes on here, but they're all nicely oriented in the manual. And then the other open resections, as we go down from least to most aggressive: segmentectomy, lobectomy, bilobectomy. And then those are just different flavor in the ordinary pneumonectomy. That's the whole lung. Forget about the extrapleural pneumonectomy, but there's a primary, which is the more common, and a completion, wherein a patient previously had a lobectomy, segmentectomy, and they're coming back just to take out the rest. Here's a pretty aggressive thoracotomy is a term for the approach to an open intrathoracic procedure, just cutting through the chest. There's the lung right there. There's the heart. I can tell this is not primarily for lung surgery, but rather for open chest compressions and defibrillation. You can see the paddle defibrillator right there. I think this patient was probably a trauma patient, and they'll sometimes open up the chest to compress the heart, massage the heart directly to pump. But that's a nice, healthy looking pink lung. So now I've just put the codes in for pro forma, just in case you have handouts for this. You can refer to the codes there. And this is actually another little nuance in the wedge resection. So for your first wedge, and then the second wedge resection on the same side. Okay, this is the add-on for the same side, multiple wedge resections. Whereas if it's a wedge resection on the right and then another one on the left in the same operative event, you would just use the one wedge twice with anatomical modifiers. In reality, that's pretty uncommon. For a patient to get a wedge on each side, the complication rate is less forgiving, let's just say. If the patient has two lungs collapse rather than there's just one. So it's not super common. But this is an important part, the second wedge on the same side, on the same operative report, the same operative episode. And then remember the wedge resection, the diagnostic, followed by the anastomotic, or the anatomic resection, a lobectomy, a segmentectomy, or a pneumonectomy. Now we'll look at this videoscopic or VATS types of resections. So this is what it stands for: videoscopic assisted thoracoscopic surgery. Just another one of those initialisms I'm grateful to have in medicine. It's quite a mouthful. Think of it as laparoscopy for the chest. It's mostly the same procedure options as the open. Again, there's a few additional and there's a few lacking. There's not a perfect crossover. But here's what it would look like. And just like laparoscopy, there's usually a video port and a couple of instrument ports. So you have the camera, which is placed. Here it looks like we have some forceps, and this looks like a hemostat being inserted in preparation for inserting another trocar, like a tube, and then an instrument through that. In any case, two is almost always done, at least, and 3 is not uncommon. And here's what it might look like. So if we're looking through the camera port, we have a stapler, see the familiar Endo-GIA stapler. That's that same sort of brand is used in abdominal surgeries too. And these have these really cool articulating wrists and elbows. They can get all sorts of little angles in there to get around and staple this way and that, all through that one port. So this is just another view of this similar kind of VATS resection that depicts better these staples. You see there's a kind of a not perfectly inserted staple, but also this line of staples here, this line of staples here, and there's the wrist and the VATS stapler, the GIA stapler. That can bend in any different directions, and here's some forceps being used to retrieve that wedge resection out through the patient's chest wall. This may be an apex wedge resection, which may be the one exception where would not require multiple firings of the stapler. So because it's already at a point, it can just be stapled across and removed, but just virtually anywhere else would require at least 2 or multiple firings of that stapler. And so here's a list of the codes related to that. They should look familiar, like the open, and the same kind of concept with the second wedge on the same side, and the wedge followed by anatomic resection too. So the order of things is important to note if there's a sequence of events. If there's a wedge resection that's followed by an anatomic resection like this, it totally changes the code. It's no longer this. It's no longer a wedge resection. It becomes the one that was then followed by the anatomic resection. So chronologically, let's say a lobectomy was performed, comes after the wedge, but that becomes the main code, and then the wedge resection becomes the add-on code in effect. So let's go down the rabbit hole a little bit further with these multiple resections, because this can get kind of muddy too. So a few scenarios let me describe, and the idea is to tell the story through the codes, the sequence of events, and the location on the lung and the side where the concept isn't implicit in the code, if that makes sense. Like you can't use a right and a left, interestingly, on these lobe resections. So sometimes a use of a modifier for contralateral wedge resections, as I mentioned a few slides ago, does require a modifier. It's a 59 modifier just to tell the codes, tell this computer through the codes that it was a different resection, because you couldn't use the laterality modifiers. So an ipsilateral, same side, subsequent wedge resections, that's the add-on additional wedge resection code. Okay, that's pretty straightforward. Then we have the same side, more extensive resection on the basis of a diagnostic wedge resection. So that's the one, remember, that's sort of, you flip it around and the more extensive resection becomes the primary CPT code. And that diagnostic wedge resection that came first chronologically now becomes an add-on code to the main CPT. So that's important to note. Now, how about, we're getting increasingly weird and uncommon for this, an ipsilateral, like same side, same lung, say right lung, that had a wedge resection in the upper lobe and a lobectomy of the lower lobe. Okay, so speaking through the codes only, it would kind of seem to be this, because we don't designate the codes by lobe. So the payer scrubber is going to think it really should be this. So how do we work that? We're saying, no, really, we did a right upper lobe segmentectomy, right lower lobe ectomy. We have to use a 59 or whatever other X modifier that you use. It's not the add-on. Remember, it's not the same site. It's not followed by extensive resection. And then we fall back into the scenario I mentioned a moment ago. Less was really uncommon: contralateral wedge resection or extensive resection. Speaking through the codes, it kind of looks like you did the diagnostic wedge and then more extensive resection, but we're actually on opposite sides. You can't use the right-left. So we have to code it as you did, and also with a 59 modifier. So just take your time if you're new to coding these. If you have a multiple resection like this, and work through it, you should be good. So here are some examples of how that might shake out in different scenarios too. So we'll start in the same place, which is right upper lobe, open wedge resection. The previous biopsy and known cancer is in there, was sent to pathology to check the margins. Okay, so we've got your basic therapeutic wedge resection, 32505. Now let's say the margins were not clean and it required another wedge resection adjacent to that, in the right lower lobe or right middle lobe. Then you just simply have the second wedge resection add-on code here, 32506. Now, what if it was in the opposite lung, left middle lobe, and left middle lobe? Again, this is the uncommon scenario, but if done, we use the same therapeutic lobe, therapeutic wedge resection code here, but we have to use a 59 modifier to distinguish it as not being an add-on. It's other lung, okay? It's not ipsilateral, it's contralateral. Whereas if that wedge resection was followed by a lobectomy, but a different lobe, then it's no longer that wedge resection followed by therapeutic excision of the same place. This is a different lobe. So we use the wedge resection in one place, the right upper lobe, and then we use the lobectomy of a different lobe. And so we have 32480 with a 59 modifier there for the wedge resection too, to distinguish it as not being followed by a therapeutic excision of that same lobe. Hope that's okay. Okay, decortication, fancy word, often called a peel, pleural peel, and this can be done open or VATS as well. Now the peel, what this stuff is debris, cellular tissue, fibrinous stuff from an empyema. So it was once pus and is now sort of coalesced into this glutinous mass of stuff that's stuck to the lung, the pleura, the parietal pleura against the visceral pleura of the lung. Now this is also called fibrothorax. Now this is an important distinction in CPT coding because there is such a thing as fibrin deposits from a hemothorax, right? It's just the breakdown products that are left over from blood. That's fibrin deposits. That's counted as more of a foreign body. So this is a point you could easily be confused. So take care that a fibrothorax is subject to decortication, and fibrin deposits are subject to a different CPT code, okay? Also, these decortications, all that pussy stuff that's stuck to the lung might also be stuck to the parietal pleura to a lesser extent, so there may be some adhesions that are lysed. That's all part of the decortication. And decortication just it involves removal of the outer layer. You'll see decortication in other contexts in medicine as well, but when we're talking about pulmonary medicine, it's peeling off the outside of the lung. So it's a quick reminder of what the empyema followed by fibrothorax looks like and the difference between a drainage and decortication. So you remember previously the patient was upright and it showed there was a huge amount of pus here at the bottom of their right lung. If that was allowed to persist there, it would coalesce, it would tighten up, and it would form this constricted layer around the right lung. You can really see how this right lung is a lot narrower and less tall because it's been constricted by that cortical layer around the lung. You can kind of see some of this fibrinous texture around the lung as well. And then the transverse section, right lung, left lung, much smaller, and you can see that kind of residual garbage from the pus lining the lung right there. This looks like there's a little bit of a pneumothorax as well. So we got to peel that stuff off and allow that lung to fully expand to its normal extent and function. So the open decortication, you see the familiar passage between the ribs, and you'll see this is the stuff, the peel, stuck to the lung. And they just basically, the surgeon will pull it off piecemeal, little by little, taking care not to hopefully penetrate the visceral pleura and cause a pneumothorax. And they just peel it off, and it looks like, nasty cottage cheese, and then you have this nice clean, expansile visceral pleura, and the lung inside is able to fully expand inside the thorax. Works pretty well. And then VATS decortication, a little harder to tell what's going on, but you get the idea. It's the same thing, just done through a scope. There's an instrument right here. It's pulling off the peel, and this can require a little bit more tedious dissection with multiple instruments too, but it's, again, less invasive and preferable if the decortication is not too extensive. So there's the main distinction between a partial and a total decortication, and there's no clear distinction between those in CPT, and there's actually no clear definition among the pulmonologists and cardiothoracic surgeons that I've spoken to. They apply different criteria, like if it's more or less than 50% of the surface of the lung. I just put the ball back in their court and said, you apply whatever criteria you think. As of 2018, CPT doesn't provide that distinction. So if it's a total, call it total. If it's a partial, it's a partial. Now, It gets a little bit into the weeds as to additional procedures done at the same time as a VATS decortication. With a partial, there are no edits too, so there might be a pleurodesis, a pneumonolysis, wedge resections, pneumonectomy, lobectomy, all these kind of things can be done with a partial. But with a total, there are some total decortication, there are some edits. Not against pneumonolysis, not against, or is against a wedge resection, not against therapeutic, but with the diagnostic, not a therapeutic wedge resection, not a lobectomy. I guess the takeaway message, and it's probably a dynamic situation too, is just run your edits and make sure that you're cool and not any additional code deletions or modifiers may be needed. Here are the codes for a fibrin deposit that I was cautioning you not to confuse a decortication or a fibrinolysis for a cortical peel. And these are the intrapleural foreign body or fibrin deposit. So a fibrin deposit is a much more discrete, distinct little remnant of a clot from a hemothorax that's much less laborious to remove than a cortical peel. And there's straightforward open and VATS approach. And these so-called foreign bodies could be a number of things. It could be the fibrin. It could be a calcification, which would be almost either further evolution of the fibrin into just mineral. Could be a bullet, piece of shrapnel, something like that. Or again, the fibrin from the hematoma consolidation too. So that's pretty straightforward when you see what's going on there. A pleurodesis is a procedure when we first learn about it, it seems like it would be the last thing you'd want to do, which is to fuse the visceral pleura and the parietal pleura together, which eliminates the intrapleural potential space when there is an underlying disorder which causing blood, fluid, or air to fill that intrapleural space. But it actually is pretty successful. It only makes things like lung transfusions or transplants more complicated because the pleura are now fused together and therefore less able to remove the old lung and put in the new with a nice pleura. Also, lung resections are more complicated. Will need to be done open with removal of the parietal as well as the visceral pleura, whereas there's no longer a space in between where we can distinguish the lung for the resection. So it's a fusion of the visceral pleura to the parietal pleura by a number of means, mechanical or chemical, as we say. So the mechanical involves literally scrubbing the surface of the lung, the visceral pleura, with a slightly abrasive pad or even a piece of gauze to roughen up the surface, and it reacts to that by scarring to the parietal pleura inside the chest wall. That obliterates the pleural space. A chemical pleurodesis, more common these days, uses an irritant substance like talc or tetracycline. There's a few other chemicals that they can instill even without a VATS, just through a catheter, through a thoracentesis, and that causes the same effect. The surface of the pleura, parietal and visceral, become irritated and they scar together and obliterates the space. The more common indications for these are for recurrent pleural effusions and pneumothorax, where you have respectively fluid or air entering the pleural space. A hemothorax is, you could plausibly do it, but usually there's something bigger going on that needs to be fixed if you have a hemothorax that's going to require something more aggressive than a pleurodesis, and right then and there. Now, these can be done in combination with a couple of other procedures, clinically and CBT coding-wise. Bleb or bulla excision off the surface of the lung, which might have been the source of the pneumothorax. Bleb and bullae are respectively bubbles on the surface of the visceral pleura, which can be thin, susceptible to spontaneous damage and rupture, and that causes the pneumothorax. So a surgeon may elect to remove the bulla, and for good measure, or in the presence of other smaller bullae or blebs elsewhere in the lung that don't require resection or excision, do the pleurodesis. A wedge resection or lobectomy as well. Same idea, removal of the offending lesion and then obliterate the pleural space so that nothing else can accumulate there. So mechanical pleurodesis, here you see on the left, the operator is using a piece of gauze, balled up gauze on a forceps and just scrubbing the surface of the lung and causing it to scarify. And on the right, there's talc. It looks just like baby powder that's been instilled into the pleural cavity, and we're just visualizing this through a VATS prior to the actual physiologic process of the pleurodesis fusing together, which is why you can still see it on the surface. So to code pleurodesis, it's fairly straightforward. If it's from least to most aggressive or invasive here, 32560 for instillation through a chest tube. That's like the tetracycline or talc slurry. I'll just mix it up with saline, shoot it in a chest tube. And if the patient isn't actively having a pneumothorax at that time, which is usually the case, they'll take the chest tube out. It's not implausible the patient might have a pneumothorax that they just cannot treat, and they'll instill the talc or tetracycline and then leave the chest tube in, but it's more likely to be a two-step process to heal the initial pneumothorax and let that take the chest tube out and then come back at a different day, or when it's at the end of that hospitalization, shoot the talc in there and then close it up. But done by a VATS, by either mechanism, chemical or mechanical, and then open. It would really be kind of uncommon to do an open pleurodesis with chemical when you could have put it in by either of these far less invasive maneuvers. So it's not very common. So this is mechanical, almost by definition. There are some edits against the pleurodesis. Again, this is just looking at it from the opposite direction when we're talking about the biopsies. There are edits against biopsies, but not the resections, as you saw earlier. Now here are our blebs and bullae. Simply a large bubble in the visceral pleura of the lung. It's susceptible to leaking. Here's a lung clearly of a smoker with this nice cluster of bullae. So how to take care of coding a bleb or bulla excision as the recurrent source of, or a source of recurrent pneumothorax. Now there is the potential for a therapeutic wedge resection of the entire piece of lung upon which the bleb or bulla was present, but it's usually, in the truest sense of the code 32655, it's just a resection of just the bleb or bulla itself. Now it's commonly done with a pleurodesis. So we have to see in the descriptor of 32655, it includes any pleural procedures. So it's a head scratcher because a pleurodesis is commonly done with the bulla excision. There isn't an edit against 32650 pleurodesis, but there is a CPT assistant that says we do only code the 32655 only. As of at least 2018, that was still in effect. So that kind of clarifies a little ambiguity with CPT. The pulmonary thromboendarterectomy, there's a mouthful, that's a PTE. This is a pretty advanced procedure that's done. I told you there would be at least one procedure for pulmonary artery disorders. And this is a procedure done for thromboembolic pulmonary hypertension. Remember, that's the third kind of obstructive, occlusive pulmonary hypertension. And that's when there's a bunch of organized clot and atheroma inside the pulmonary arteries, occluding the blood flow through it. This is a pretty advanced procedure, and it's got sort of a garden variety version, which is still a huge deal, but there's also the much more aggressive and advanced one that's being pioneered by UCSD, in which the patient's body's cooled down to 65 degrees Fahrenheit, and their heart is completely arrested. The lung is completely exsanguinated, removed of blood. There are codes for the sort of ordinary pulmonary thromboendarterectomy with and without bypass at 33910, 5, and 6. But the more advanced and aggressive type with the profound hypothermia and the total arrest, and the much more detailed removal of the thrombus right down to these tiny subsegmental pulmonary arterioles, this is, as of 2018, requires an unlisted code if you work at one of those centers where they do this type of PTE. Now this is the clot and the atheroma and so forth, the gunk that fills the pulmonary arteries. It looks like it was almost completely occluded, and gosh, look how nice it comes out in just one big piece with a lot of tedious dissection. It looks like, you know, when you're eating snow crab legs and you get that one really delicious piece that just comes all out in one piece. You dip it in the butter and go to town. Anyway, it's much more satisfying for patients to have PTE like this. Apparently, it's a very miraculous recovery, and the people on death's door leave the hospital feeling 99% better. It's pretty remarkable stuff. Well, I have been Ed O'Byrne, hanging out with you for the last hour and a half or so. I hope that's been interesting to you. You're welcome always to email me if you like, if you have a question, comment, or correction, eoburn@hrgpros.com there. It's been a pleasure, and we'll see you the next time around. Take care.